Morning, everyone, and a very warm welcome to this breakout session as part of our virtual conference entitled Interstitial Lung Disease in Systemic Sclerosis. Thank you so much for joining us today. I hope that you're all enjoying our virtual conference experience. If you haven't already, do please feel free to connect with any of our exhibitors, and don't forget to check out our health and wellbeing zone. My name is Helena Einan, and I'm the Communications Officer at SR UK. Some of you might sort of know me already, and I will be your host for this session. Hiya. Please can I ask you to ensure that you're muted while the session is in progress and have your cameras turned off. We also ask that you don't record, screenshot or take photographs during this session. It gives me great pleasure to introduce our expert speaker, Dr. Elizabetta Renzoni. Dr. Renzoni is consultant physician working in interstitial lung disease at the Royal Brompton Hospital, and she is also senior lecturer at Imperial College. Dr. Renzoni's key research interests include prognostic and outcome biomarkers in lung fibrosis in systemic sclerosis, and she is also an associate editor for respirology. Dr. Renzoni also chairs the European Respiratory Society Group for diffuse lung disease. I will hand over to Dr. Renzoni, and you will have the opportunity to ask questions. Do please submit these via the chat function during the presentation. My name is Helena. If there's anything slightly more personal, do feel free to send it to me and I can anonymize it. We will then do our very best to answer as many as we can after the presentation during our allotted time. So without further ado, I will now hand over to Dr. Elizabetta Renzoni. Thank you.
Thank you very much, Helena. I'm just going to check that I can share the right. Yes, I've got it. So it's thank you, Helena, for that introduction. And it's a real pleasure to be here. And I'll be speaking for about 20 minutes about scleroderma-associated ILD, and then we'll move on to the discussion. So in interstitial lung diseases, the part of the lung that is affected is the interstitium, which in healthy lungs is a very thin space that's a membrane pretty much that separates the air sac from the red blood cells. And its thinness allows easy passage of oxygen and carbon dioxide in and out of the red blood cells. And then in interstitial lung disease, the interstitium becomes thickened by a combination in varying degrees of inflammatory cells, of inflammation, and scar tissue. So interstitial lung disease is frequent in scleroderma, but in many patients it is limited and will not progress. And indeed, as you can see here by these two sections of CT, two slices of high-resolution CT, on the left you have a lung that is essentially normal. And on the right, you have a section of the lung that is whiter than the normal lung. So you can see here what we call ground glass, this diffuse whiteness of the lungs, and within it there are what we call traction bronchiectasis, so these airways which shouldn't normally be seen, which are visible because they're pulled apart by the surrounding fibrosis or scarring. There are some risk factors for the development of ILD: older age and male gender, certain types of autoantibodies, so anti-topoisomerase or ATA or SCO70 is almost always associated with a degree of ILD. Anticentromere antibodies or ACA are instead, by contrast, rarely associated with significant ILD. It's the first years from the diagnosis of scleroderma when we think the major drops in lung function occur, if they are going to occur. And then diffuse skin disease is also associated with a higher likelihood of ILD, although we see ILD in limited skin disease as well. In the early stages of scleroderma, the ILD can be asymptomatic. And that's the reason why we would do lung function tests and a high resolution CT in all patients newly diagnosed with scleroderma, because the lungs have a degree of reserve, and the patient may only become symptomatic when a certain reserve has been lost. Cough is common, can be caused by the ILD, but can also have other causes, including in scleroderma, quite frequent is reflux of stomach contents up to the throat. Breathlessness initially is only present on strenuous exertion, such as walking up steep inclines. And then if the fibrosis becomes more extensive, breathlessness can also occur on walking on the flat or on relatively minor activities. Of course, breathlessness can have a whole variety of causes. It can be musculoskeletal issues, so muscle, joint problems, heart disease, loss of fitness, and others. Lung function tests, most of you are probably familiar with lung function, but they allow evaluation of the airways, the interstitium, and the lung vessels. And we would recommend doing complete lung function tests, and I'll speak about these a bit more. But the most important parameters for us in patients with scleroderma are forced vital capacity, or FVC, and the diffusion capacity for carbon monoxide or gas transfer, or DLCO. And so lung function tests are useful at presentation to know the level of involvement, and on follow-up to assess response to treatment, to monitor if we're not treating or we're not changing treatment. And the frequency of lung function tests will vary and will depend on the risk of progression, the extent of the disease in the individual patient. So forced vital capacity, or FVC, is the variable that we most use to look at changes over time of the ILD. It has been the primary outcome of all of the recent scleroderma ILD trials, and I'll show this. And gas transfer, or DLCO, is very sensitive to ILD extent, but it can also reflect pulmonary vascular involvement. And therefore, it's not specific only for ILD. And indeed, if you have a drop in gas transfer that is not paralleled by a worsening of the ILD on CT or by worsening FVC, you could think about the development of pulmonary hypertension as a possible complication, or at least of pulmonary vascular involvement. And screening tests for pulmonary hypertension include an echocardiogram, serum levels, so markers in the blood, what is called BNP, and a desaturation on a 6-minute walk test. So as I said, all patients at baseline will also have a high resolution CT, and the high resolution allows a capture of images with greater detail than a regular CT. And here is an example. These are essentially normal lungs. There may be a little bit of faint ground glass here. And we go from very limited ILD, these are sections of sort of as if the lungs had been sliced, going down towards the bottom of the lungs. And you can see here, the majority is normal lungs. So the black lungs and the little dots, that's all normal. The dots are vessels. And what is probably the beginning of an interstitial lung disease are these little lines that you can see here at the back, at the basis of the lungs. This here is the heart. On the other hand, we can have extensive ILD, which becomes more extensive as we go down towards the basis of the lungs. And you can see here how the lungs have become, a lot of the lungs has become white. So this is what we would call ground glass, but the airways are also more evident. And here they are. They're these little tubular, slightly distorted structures. And these are airways being pulled apart by the surrounding fibrosis. So this would be an example of extensive ILD. What are predictors of worsening? We know that if disease is already extensive, it will have a greater likelihood of continuing to progress. There are certain autoantibodies that are associated with a greater likelihood of progression, and among these, anti-topoisomerase or SCO70. Early disease, so as I said earlier, it's the first year since the diagnosis where we have to be most careful about significant drops in lung function. Diffuse skin disease tends to go with a greater likelihood of progression. Short-term lung function will be a predictive factor. And in a study funded by SRUK, we have been looking at the effects of microaspiration on long-term lung function changes, but I'm not going to be showing this here today. So from a large European database of scleroderma patients, the USTAR database, it's clear that there is great heterogeneity in how patients progress over time or don't progress over time. So on the y-axis here, you've got our FVC predicted. So the forced vital capacity, you can see that in some patients in the green line, it actually improves. In the yellow line, it actually is stable, and these represent a large proportion of patients with scleroderma. There are some that first are stable and then progress. Others progress more rapidly to begin with and less later on. And only a small group, less than 10%, progress very rapidly initially. So great variability in the clinical course of the disease. So from what we've said, when disease is severe, because we know there is a high likelihood of progression, we would usually treat. And the decision to start treatment is straightforward. Treatment decisions can be more difficult in the group of patients that have only very mild disease because it may be stable over time, and therefore the importance of monitoring over time with lung function symptoms, CT if unsure. And then we are learning more also about other subsets that might help us make these decisions. So I'm just going to go through clinical trials that have been performed in scleroderma ILD, and if something is unclear, we can then discuss later. The SLS1 trial was the first trial to look at cyclophosphamide. There was also a UK trial called FAST, which was looking at IV cyclo, which reached very similar conclusions. Here, again, on the y-axis, you have FVC. So you're looking at changes of the forced vital capacity, the lung function parameter over time. In the empty dots are the cyclophosphamide-treated patients, black dots placebo, so no treatment. Patients were treated for a year. Here you have 12 months, and then followed up for another 12 months. The biggest benefit from cyclophosphamide was actually seen 6 months after having stopped it compared to placebo. But you can see that then a further 6 months of just observation meant that there was no difference. Any benefit that had been seen with cyclophosphamide was lost, and there was no difference at the end with placebo, suggesting that you need to continue treatment with immunosuppression. Cyclophosphamide is an immunosuppressant, so a drug that dampens the immune system. But with a drug that is less toxic than cyclophosphamide, cyclophosphamide is associated with risk of cancer, including bladder cancer and blood cell cancers, if used for long periods of time. So the SLS2 trial was designed and completed and published in 2016, comparing mycophenolate against cyclophosphamide. And there was, again, we've got FVC on the y-axis, and you can see that over the course of 24 months, so 2 years, there was an improvement, a small but significant improvement compared to baseline in FVC that was pretty much identical between mycophenolate and cyclophosphamide. They also, both groups had an improvement in breathlessness scores and in skin scores, but the mycophenolate was by far better tolerated because of less side effects, essentially, to the white blood cells, with lowering of white blood cells, and fewer patients had to stop before the end of the study. And then more recently, we've had a number of trials looking at tocilizumab, which is an anti-IL-6 drug. And IL-6 is a key inflammatory cytokine. So tocilizumab is an anti-inflammatory drug. And the trial was designed to look at the change in skin scores, so looking at skin disease as the outcome. But a key secondary outcome was, again, the change from baseline in FVC. It's important to note that these were very selected patients, so they all had to have early disease, diffuse skin disease. They had to have at least one marker indicative of inflammation, so CRP, ESR, increased platelets, and no other background treatment was allowed. I will focus here on the patients with scleroderma ILD in this trial, which were about 2/3 of the whole trial. And if you look here, you've got on the y-axis FVC, and in red, tocilizumab treated patients, in blue, placebo, so no treatment. And you can see the FVC is completely stable on average, compared to quite a significant fall in the placebo-treated groups. And so on average, patients that were not getting treatment lost about 1/4 of a liter, 250 mils, compared to essentially no loss, only 20 mils in the tocilizumab treated group. And based on these results, tocilizumab has been licensed for treatment of scleroderma ILD in the US, not yet in Europe or in the UK. Then we come to anti-scarring agents, and in particular, nintedanib, and this was the Census trial that looked at a different subset of patients. These had to have fibrosis on CT, extensive fibrosis on CT, relatively early disease, and in this trial, background immunosuppression was allowed. And in this trial, if you look light blue, again, you've got FVC here on the y-axis, light blue is placebo. The treated group is nintedanib. You can see that the nintedanib treated group is dropping their FVC more slowly, although the nintedanib doesn't completely stabilize disease. And these are patients who already have extensive lung fibrosis and therefore are more likely to progress. However, nintedanib had no effect on breathlessness or quality of life. Diarrhea is a significant side effect, and there was no effect on skin disease. Then we have a number of trials, and I just wanted to mention Recital trial because it was run here in the UK, the Brompton, the Royal Free. Toby Mayer was the chief investigator, comparing rituximab, which is a drug that eliminates temporarily B cells, a certain type of white blood cells that produce antibodies. And so rituximab against IV cyclophosphamide for 6 months. And the primary outcome, again, is the FVC change at 12 months. The trial has now been completed. The results are being analyzed right now, and they should be available early next year. So what do we know about treatment so far? The standard of care at the moment is mycophenolate for patients with scleroderma ILD who need to be treated. In selected subgroups with high likelihood of progression, treatments such as anti-IL-6 could be an option, although not yet licensed in the UK. Other treatments such as rituximab have shown promise, and the Recital trial should help us see its effect. And then for patients with significant fibrosis, nintedanib has been shown to slow down the progression of disease. We do need now that we have a number of agents, we will need to have trials looking at the combination of different drugs. What is the effect of different combinations of treatments? For example, there is one trial going on at the moment, the SLS3 trial, that is looking at mycophenolate combined with pirfenidone, another antifibrotic drug. So thinking about possible treatment strategies for scleroderma in patients with mild ILD, low risk of progression, we would simply monitor. If disease is more extensive or is progressing or is high risk of progression, we would go for immunosuppressive treatment. And then in more extensive disease in a later stage, if the disease is still progressing, we would consider combining immunomodulatory with antifibrotic. And there is the possibility of treating early in order to prevent development of fibrosis in certain subgroup of patients with drugs such as tocilizumab, for example, but this would be in a highly selected group of patients. I just wanted to mention exercise and physical activity, and this working group is particularly focusing on scleroderma. There's also Kim Fliggleston from the UK, Anne-Marie Russell, and a number of scleroderma specialists highlighting the importance of physical activity, pulmonary rehabilitation. We know it works in IPF, but there are no studies looking specifically at scleroderma ILD, and this group is now looking into this and looking at how to encourage and support patients in exercise and physical activity. We've performed, and I need to wrap up, but we've done a study looking at oxygen in patients with fibrotic ILD whose oxygen drops during a 6-minute walk test. I'm not going to go into details, but patient who declined on a 6-minute walk test whose oxygen saturation dropped to less than 88% were included in the trial. A number of outcomes were met, but this was one of the most significant. So in answer to the question, has your breathlessness changed over the last 2 weeks? The majority of patients after the 2 weeks on oxygen felt better compared to the 2 weeks without oxygen. And then finally, lung transplant, which is considered only when there has been no response or insufficient response to treatment and survival is severely shortened without an intervention. And scleroderma patients have had trouble with acceptance onto lung transplant list because esophageal involvement, so gullet involvement, is often a barrier, as it is thought to cause trouble to the transplanted lung. But in this review study that looked at 90 patients across Europe with scleroderma and lung fibrosis, survival rates in scleroderma patients were similar to lung transplant patients with other diseases. So 81% alive after 1 year, 61 after 5 years. The risk of death was higher in female patients, but particularly in patients with pulmonary hypertension. But the study suggested that scleroderma per se should not be considered a contraindication to lung transplant, although there is the issue of the esophageal involvement, among others, that needs to be considered on a case-by-case basis. So in conclusion, I think it's a very exciting moment for scleroderma ILD. There have been a number of recent trials. There are trials going on that really offer hope for patients with scleroderma ILD. Now that we have a number of drugs for scleroderma ILD, we also need trials looking at different combinations of treatment. And one of the challenges for the future is to decide, once you have an array of drugs that can be used, how to customize the treatment to the individual scleroderma ILD patients so as to optimize benefits and minimize side effects. And there is also increasing evidence that self-management strategies such as exercise on a regular basis can lead to improvements in quality of life and symptom benefits. And with this, I think we can move on to Helena chairing the the chat questions. Thank you for any questions.
Thank you, Dr. Renzoni, for your excellent presentation. That was amazing. Thank you. We do have quite a lot of questions that have come in, so I think we'd better get started. We have a question from Janet, who has asked, can bronchiectasis, is there any link, between bronchiectasis and interstitial lung disease? I have bronchiectasis. Is there a link with ILD?
Okay, so thank you for that question. So with ILD, you can get traction bronchiectasis, and that's the airways being enlarged by surrounding fibrosis. That is different from freestanding bronchiectasis. So if one is told you have bronchiectasis, but there is no fibrosis, it's just bronchiectasis, it's more likely that is freestanding bronchiectasis. So that is an airway issue, which is very different from traction bronchiectasis, which are seen in the context of an interstitial lung disease. So there are two different entities.
Thank you. Laura has asked, does having small airways disease make it more likely that you might develop ILD? And she says she had no lung issues prior to scleroderma.
Okay, I mean, again, one would have to know more about the details of an individual case, but small airways disease would not necessarily lead to developing ILD if they're isolated. So if it's isolated small airways disease, no, it doesn't lead to ILD. Although it would be an unusual manifestation of scleroderma in itself, and it might be a manifestation of an overlap syndrome, because you can see airways disease isolated much more commonly in diseases such as Sjögren or rheumatoid.
What is the best form of exercise for ILD? That's a great question.
Yeah, great question. Great question. And again, that would be individualized, but on courses of pulmonary rehabilitation, usually do a mixture of aerobic and strength training. So you would do a mixture of either walking on a treadmill or, exercise bike together with weight training. And there are specific pulmonary rehabilitation courses for patients with lung fibrosis, including scleroderma. Now, the problem is that they are not specific to scleroderma, and there may be variable access to pulmonary rehabilitation, particularly now during the pandemic. So it can be difficult to access pulmonary rehabilitation, but we would support that. And also, a great form of exercise is walking, of course, and walking, cycling, any exercise that one feels comfortable doing would work. Then there is the issue of oxygen, and if one has severe disease and therefore the oxygen drops during exercise, I'm very convinced that using oxygen during exercise improves your possibility of getting fitter. And indeed, there is a trial going on in Canada at the moment looking at oxygen and the effect on pulmonary rehabilitation. But this is only for patients that desaturate on exertion.
Okay, thank you. A question about the terminology. This is from Jennifer. What is the difference between ILD and NSIP? So the difference between ILD and NSIP, please.
Yeah, absolutely. Very good question. So ILD is interstitial lung disease overall. NSIP is the pattern, and the CTs that I showed on the slides were all NSIP pattern. So it's called non-specific interstitial pneumonitis, not helpfully. It's not a helpful name because it says non-specific, but actually it is quite specific, especially for scleroderma patients. So NSIP pattern is a subtype of ILD. So it's how it looks either on biopsy, but we don't do biopsies anymore because they don't add, or on CT. And an NSIP pattern is characterized by that ground glass that I showed, the lower zone predominance, and it is the pattern that is by far the most common in scleroderma ILD. So it's one of the types of ILD, NSIP.
Thank you. We've got a question now. This is about prognosis. Alicia has asked.
Helena, sorry, we can't hear you that well.
Can you hear me now?
Yeah, just if you can come closer to the computer.
Like that?
Yeah, perfect.
Wonderful, thank you. It's a question about prognosis. It's from Alicia, so thank you for your question. She asks, what are the statistics for survival for with diffused systemic sclerosis, please?
So with diffuse skin disease, I am not sure of the more recent studies looking at the statistics of survival in diffuse skin disease, because I've tended to look more at ILD independently of the diffuse skin disease. So this might be a question better posed to someone like Professor Denton, who has those figures up to date. Okay. I'm sorry about that.
Next question. This is interesting, actually. This is from Linda. Can lung function tests be affected by poor technique? I suppose poor technique on the part of the technician, perhaps.
Yes, or poor technique on the part of the patient, difficulties because of cough, difficulties with coordination. Yes, they can. There are some tests that are more affected by technique, both the technician and patient, and some that are less. The gas transfer is the test that tends to be most variable between different lung function laboratories. Whereas FVC is more reliable, but still, yes, they can be affected. And that's why in a lung function lab, you normally get asked to do it quite a few times so that one is sure to have got the best measurement, because one on its own may not be your real measurement because of difficulties with technique and variability between one effort and the other. And that's also why we speak of intermeasurement variation. So, you know, if the FVC drops by only 5% between one visit and the other, could it simply be due to the fact that whenever you measure something, whether by effort, by technician, by, you know, whatever series of parameters, there will always be a little bit of a difference. And so if the difference is small, we might just say, well, let's repeat it again in another 6 months, because you're not quite sure whether it's real or not.
Okay, thank you. Is it possible to have lung progression when blood work is normal, but the person is still experiencing increased shortness of breath?
Yes, of course. Yeah, yes, it is possible. So the focus trial that I showed on with tocilizumab, of course, had focused on patients with raised inflammatory markers, but many patients don't have raised CRP or raised ESR and can still have progression of the lung fibrosis. So I would look at the lung function, CT, symptoms across the board, because blood markers will not tell you anything about lung function worsening in the majority of patients.
Okay, thank you. Question from Melanie. Can Can an increase in dosage of mycophenolate affect skin ulcers? Please.
Now that is more a question for the skin doctors, I think, for the, for the diffuse skin disease. So the answer to that is I don't know. I think skin ulcers are more related to the vasculature, and I know they're treated with drugs such as bosantan, so drugs that dilate the vessels in the fingers. So I don't know. I think mycophenolate is known to help with skin disease, but that's the skin thickening. I would imagine that for skin ulcers, one would have to think about vasodilators, but it's not my day job, so I can't.
Okay, thank you. I think we might only have time for one more. This is a question from Jennifer. This is about the tests.
Okay.
When I have a PFT, I'm forced to blow so hard that I cry and I feel worse. They don't understand that I can't do this properly. Do you have any suggestions to combat this?
So first of all, I'm really sorry to hear that. And I know that a lot of patients find lung function very stressful. I guess one thing would be to discuss with your chest physician, with your IOD doctor, how often do you need to have the tests? Could one look at slow VC and gas transfer? I think it's something to discuss with the physician, because I know that lung function can be quite stressful.
Thank you very much. I think we've got time for one more. This is a question from Jennifer. Hi Elizabeth, I have to fight to get an HRCT from my doctor. Is there a better way to get my doctors to offer me this instead of an ordinary X-ray? So it's about testing.
So the CT, we would just to when I said about the HRCT, it was that I think all patients should have an HRCT at baseline, and therefore if this is baseline that we're talking about, to me it sounds as though one needs to be under a scleroderma specialist, so a rheumatologist or a lung specialist, and therefore all the tests will come from there. Usually GPs are not sort of, the experience with scleroderma is relatively limited because scleroderma is a rare disease. So I would suggest that one asks for a referral to a specialist center, so that then the decisions about CT and stuff can come from there. In terms of the CT, I just wanted to highlight, however, that while I would recommend all patients having it at baseline, I wouldn't recommend having regular CTs, but only deciding that together with the physician if there is a worsening, because of course CTs do expose you to radiation. Scleroderma patients are often young patients, middle-aged patients, and you wouldn't want to be doing CTs on a regular basis if not needed. So whereas we would do lung function on a very regular basis, CT after baseline would be done if there are changes that need to be explained. I don't know if that's clear.
Thank you. Thank you, Dr. Renzoni, for that. There is one more question that I'd like to put to you within the time, please. It's a question from Dora. Is it possible to treat ILD while having MAC infection and MAC being
Mycobacterium avium complex? Yeah. Yeah. Yeah, I think that's not going to be a question that I can answer without knowing more details. This would be something that would need to be looked at in the individual patient, because so Mycobacterium avium complex is an atypical mycobacteria, which causes a sort of chronic infection. Sometimes it can just be a sort of not chance, but an occasional episodic finding. In other cases, it will cause changes on CT that show infection with MAC. And so I cannot go into details because this answer and this question will depend on the individual circumstances, and I would expect would need also a discussion between infectious disease specialists and ILD specialists.
Thank you so much. I'm afraid we really have run out of time now, everybody. Thank you so much. Thank you to Dr. Renzoni for your amazing presentation and also for your responses to the questions. I'm so sorry if we didn't get to yours, but thank you so much for submitting all of your questions today. It's now time for lunch. So it is time to bring our breakout room to a close. But do please take the time to have a look at our exhibitions and to network with one another, because that's what today is all about. Lunch break is between 12:30 and 1:30. So enjoy that, and thank you very much. Goodbye.
Thank you, Helena. Thank you, everyone, for being such great participants. And I hope we've answered at least some of the questions.